So next, I would like to invite Prof Jayamini Seneviratne, who does not require any introduction to this forum. I think a well-known figure and a professor with a good scholastic abilities, and who has been a good orator as well. Over to you, sir.
Good morning, and thank you very much for inviting me. And I will be speaking to you about the current concepts in the pathogenesis of atopic dermatitis. And I have put it in to make it an interesting presentation, I have put it as frequently asked questions and answers to the questions. So this Socratic method of medical teaching had been in practice for so long in order to induce enthusiasm among the listeners. And in order to explain the skin barrier, I have put this slide of Israel's iron dome, by which it intercepts and destroys the missiles that are thrown up by its enemies in order to survive in a hostile environment like Israel. You need a good defense system. The concept of a barrier was basically described by Claude Bernard, which is even today true about regulatory physiology, milieu interior. But of course, he didn't coin the term milieu exterior, and the skin barrier exists between the two. If it fails, along with the adaptive immune responses, as happened to this little baby who are referred in the middle of the night with this appearance, a baby boy, you can appreciate the evidence of staphylococcal scalded skin syndrome around the mouth, herpes simplex infection, and fresh bleeding. So putting all these three features together, it's a diagnosis of Scott-Aldrich syndrome. And we started on IV vancomycin, IV acyclovir, IVIG, and more importantly, IV albumin. Did the same baby after a few days of treatment. So this is an example of the importance of doing these conditions in acute pediatric setting. Here is another child who was referred by the neurologist with fits. This child had oral ulcers, and the mother has 3 additional children. The oral ulcers were very painful, so the mother kept on applying a gel which she got from a pharmacy, which contained an anesthetic agent. So the lignocaine got absorbed and caused the neurotoxicity. So like the skin, the barrier is also expressed in the intestinal mucosa as well as the respiratory system. So coming to my presentation, does the barrier, you will see the question, I will come to the answer. It does exist not only in humans, in other animals, plants, in order to survive in this world. So this is a baby who presented with an autoimmune blistering disease, and within few days developed severe eosinophilia, 40%, which is actually is indicative of compensatory mechanism from the adaptive immune system, Th2 dominant inflammation. So basically, adaptive immune responses are antigen driven, but age of the patient or the origin of the antigen is not important. Skin is a biological, mechanical, and a chemical barrier preventing the entry of harmful agents, both macro and micro, in the environment. But it also prevents evaporation of water. So the barrier is not a one-way barrier, it's a two-way barrier. Here it's the permeability barrier that is located in stratum corneum. The next important question is, does it exist in fetal life? Yes. That's a normal neonate at birth with vernix caseosa. And what activates the barrier at birth is the drop in humidity, which upregulates aspartate proteases, resulting in an active barrier. So this, even in fetal eye, barrier defect leads to a problem like what is shown here. The so-called premature ichthyosis syndrome. Actually, it should read as preterm ichthyosis syndrome, where the baby is born with respiratory system and these thick plaques, which are made up of keratin. So in this condition, the ceramide is abnormal. The normal ceramide has two molecules, sphingosine and long-chain fatty acids. The latter is still the latter is defective in this condition. So to explain the skin barrier, we use this brick and mortar barrier. The permeability barrier is in the stratum corneum, the topmost layer, which is generated by the bottom layers. Often, even today, the textbook describes corneocytes as dead cells. I do not agree, in which case even the red cells would be dead because there are no nuclei in red cells. So stratum corneum is a very comprehensive biological barrier. Various components are shown. So there are keratin microfilaments, conified envelope, conified lipid envelope, and lipid lamellae. That's the extracellular matrix. So basically, they function as an umbrella. The keratin microfilaments are the metal bars which give strength, otherwise the cell will collapse. The main constituent is profilagrin, the protein, which play a key role in the barrier homeostasis because it's metabolized by several enzymes producing vital compounds downstream, hygroscopic amino acids, various acidic compounds to maintain the acidic mantle of skin, and also promote keratin microfilament aggregation. And some of these compounds are crucial in stratum corneum hydration. The stratum corneum functions best when it is well hydrated. These compounds are known as natural moisturizing factors. They are made up of amino acids, lactic acid, sugars, urea, and inorganic acids. The ones that we use biologically in treatment should contain lactic acid and urea. If you ever want to have a good moisturizer, they should contain lactic acid and urea, but the others are not practical to use. So the filagrin is metabolized by various enzymatic pathways. These are the ones that I have shown. Caspases are apoptosis-related proteases. They activate enzyme precursors that digest genomic DNA. As you know, the corneocytes do not have DNA because of this. They also metabolize other proteins like melanin and filagrin. Are there disorders resulting from these mutations of these enzymes? Yes. These are quite, the first condition is a novel entity, which we see from time to time, which is a overlap between psoriasis and another condition known as pityriasis rubra pilaris. Coming back to the other compound is C, and this acts as a scaffold or a palanchi, which gives the strength externally to the plasma membrane. So they contain mainly hydroxyceramides. Ceramides are now therapeutically available as moisturizers. So the extracellular matrix is made up of lamellar body extrusions, and they provide physical strength to the skin barrier. The skin barrier is generated by the bottom layers in the stratum spinosum, And these compounds, as I said earlier, are excluded in the granular cell layer. Are there cytokines in the stratum corneum? Yes, predominantly interleukin alpha, 1 alpha. The acid mantle also play a crucial role in normal cutaneous defensive functions, and this is ideally 5.5. I mentioned in filaggrin metabolites that urocanic acid, which play a key role in maintaining the acidic pH. Are there compounds which compromise the barrier function? Yes. They are mainly alkali compound. Almost all the soaps and shampoos are alkali. Perfumes contain a wide variety of compounds which are very harmful, and also the skin barrier dries up in situation like air conditioning. So in clinical practice, atopic dermatitis is prevalent in developed countries and even in our society among the middle class and above families. What are the compounds that improve barrier function? Naturally, water, because the fetus develop in a very aqueous environment. We need to hydrate the epidermis by bathing and the use of emollients. The main inflammatory skin disease which results from a barrier dysfunction is atopic dermatitis, which starts usually on the face, characterized by inflammation which is unprovoked, and subsequently it moves to the rest of the body. It often starts on the cheeks and characterized by pruritus and a propensity to develop staph infection. In the Indian subcontinent, the pigmentary anomalies are very common, and both hypopigmentation in acute stages. This is staph infection seen in a child with atopic dermatitis. I will come to that in a little while. So basically in atopic dermatitis, both the permeability barrier and the antimicrobial barrier is defective. Are they equally impaired? None of the book's articles address this. Answer is no. And this is a child who presented with molluscum on the typical atopic areas and staph infection simultaneously. So some people present with infections caused by the specific organism, atopic specific organism, which tells us that the defect is primarily in the antimicrobial. Here is eczema verrucatum, human papillomavirus infection. You hardly see any evidence of eczema here. What are the cytokines that contribute to the inflammation in atopic dermatitis? Interleukin 4, 13, and 31. Now in clinical practice, which features suggest established Th2 dominant inflammation in atopic dermatitis? By the time the infections occur, the inflammation Th2 dominance is well established, so is severe pruritus and lichenification. In clinical practice, in the majority, you can use the peripheral blood eosinophilia and the raised IgE levels, but they are not often seen in all patients. What is the effect of Th2 on pruritus? This is a video clip. This is a child who presented with hand-foot-mouth disease. And while we saw the child, we noticed that the child is scratching the area. So the moment the skin barrier is impaired, the allergens in the environment start going in. The allergens are often in the home environment, various types of foods, house dust mite, various other compounds as well. Compounds which play a major role in initiation and propagation of inflammation in AD. In order to explain this, the key cytokine here is the thymic stromal lymphopoietin, which is, as you can see, has many sources, keratinocytes, initiate the event, and then it leads to the Th2 dominant production of IL-4, IL-5, as well as other cytokines like IL-31. Now, how do you explain the sustained epidermal barrier defect leading to inflammation and pruritus? That's again the key cytokine here is the TSLP. And as I said earlier, it promotes the Th2 dominant inflammation from different sources. And once established, the pruritus can be explained by the production of IL-31 here, which acts as a neuroimmune communicator. So once Th2 dominant inflammation is established, it further reduces the epidermal barrier function. So in other words, it leads to an ever worsening scenario of inflammation. So this IL-31, as I said earlier, promotes pruritus in atopic dermatitis, is one of the most severe manifestation of the disease, and pruritus is worse in the night, so the child can't fall asleep. As you know, the growth is secreted in the night. This is one mechanism by which leads to growth retardation of these children, which had been falsely attributed to the use of steroid in the past. Allergens in atopic dermatitis. This is number one now in my clinic, the head lice. You can appreciate millions of, not millions, thousands, maybe hundreds of.
ETC カードが挿入されています。
Yeah, a lot of nicks, and also they promote staph infection. So these toxins from staph as well as allergens from head lice this is the commonest cause of disease exacerbation in my clinic now, especially after the COVID. Topical steroids are known to delay barrier recovery as well as repetitive use of emollients. So I have been using topical steroids, sometimes potent, in an intermittent manner. So you hit the inflammation, bring it under control, allowing the barrier to recover. Another method that I have innovated in the past is to use topical steroids in a rotational manner. You treat one anatomical area per day. Emollients are used after a wash or a bath. What are the criteria for a good emollient? They should be physiologically based, of course, should be cheap now, and should be user-friendly. There are some emollients which are very repair compounds, exorbitant in prices. The drawbacks of emollient use are, they are like raincoats. They act by preventing water evaporation, but they don't repair the barrier. These are very expensive. Growth retardation is a big problem in severe berry impairment because of evaporation of water. Not only evaporation of water in infected children, I have realized over the years the hypoalbuminemia. If you remember the case that I showed at the beginning of my presentation with Scott Aldrich, the standard therapy is IV antibiotics, IV acyclovir, and IVIG. But what is life-saving in pediatric practice is albumin transfusion. That's a case of Netherton syndrome. As you can see, there's a profound barrier defect leading to ingress of allergens and antigens, and most of these children do not survive. Similar to the skin barrier, I think Professor Malavagi covered this area. In some patients, oral tolerance is also play a key role in connecting atopic dermatitis to food allergy. Is a mechanism by which ingested proteins are tolerated without leading to intestinal or systemic allergies. I think I will end up there. My time is up. Thank you.
Thank you very much, sir, for that exceptional presentation and the lecture. It has been a privilege to have you on this forum, Professor Jayamini Seneviratne. And we have been, I think, you can stop share, sir, to allow the next speaker to. So I would like to invite Dr. Rajiva De Silva, consultant immunologist and head department of immunology at Medical Research Institute. Again, thank you for accepting our invitation to do this presentation on chronic urticaria, current practice. Over to you, sir.
Thank you very much. To thank the College of Physicians, Pediatricians for giving me this opportunity. So I'll be dealing with chronic urticaria, and this is the outline of my talk. So initially, if someone has urticaria, the first thing would be to differentiate between acute and chronic. So chronic urticaria is if the urticaria lasts over 6 weeks or is recurrent over a period of 6 weeks. Now, there are differences between acute urticaria and chronic urticaria. The classification of chronic urticaria is either it is chronic spontaneous urticaria, CSU, or it is induced by something else, quite often physical means, and that is called inducible urticaria. So chronic spontaneous urticaria is where you get spontaneous appearance of wheals, angioedema, or both for 6 weeks or more. Now, about 50% of patients have both urticaria and angioedema. In 40%, there is only urticaria, and in 10%, they're supposed to have only angioedema. Now, these are Western figures. Having seen several thousands of patients with chronic urticaria, I haven't seen very many people with chronic angioedema. The inducible urticarias are physical urticarias like dermographism, cold urticaria, vibrated urticaria, and non-physical urticarias like cholinergic, contact, and aquagenic.